give an overview of our team and what we do, plunging in. So we're about 5 years old. So this is a relatively new entity in the UK. And we came out of, created in the wake of the large West Africa Ebola outbreak a few years ago, where we recognized during that time that not only did the UK not really have the full resources that the country needed to respond and assist countries for outbreaks, but there's also other opportunities that are missed when we're really not ready for that. And it's not only about the outbreak, it's also about the research and knowledge gaps that we have in these sorts of settings of outbreaks of emerging diseases. And unfortunately, despite the chaos that is often inherent in these sorts of settings, it often is our only opportunity to learn about things that are important for the next outbreak. And so, for example, if you have a large Ebola outbreak and you say, well, what are the right drugs or vaccines? Really, your only opportunity, of course, to really put those into trial for phase 3 trials or when people have Ebola. And so you can't say, well, let's wait until things calm down and then work on this later. You need to really be able to put that in play during the outbreak. And then, of course, it's not enough just to deal with each emergency. We need to really work to not have emergencies in the future. That's an ideal goal that we'll get to at some point, we hope. But meanwhile, supporting countries really to respond locally and decrease dependence on outside support. We're certainly here and interested and available to provide outside support, but our ultimate goal, and I like to quote the British statesman James Bryce, who said medicine is the only profession that works to destroy the reason for its existence. And that's what we really aim to do in the long run, is destroy the reason for our existence, meaning that no one would, if there's an outbreak in sub-Saharan Africa or wherever it might be, people would say, why is there a need for anyone to come from London or Geneva or Atlanta or wherever it may be? Our partners in country, of course, have that expertise and experience to deal with these issues on their own. And so that's where we came from and put together, therefore, let me just see, a tripartite remit or objective for our team, which I'm going to just skip one slide ahead because it's here. So outbreak response, and we assist in outbreak response. You may notice that the title of our team is the UK Public Health Rapid Support Team, not the Rapid Response Team. And the reason that we chose that name is because we really wanted to emphasize that we are not flying in to save the day. We are not the primary partners here. The primary partner is, of course, the Ministry of Health or National Public Health Institute or other body on the ground where these events are happening, but we are there to support. But we're also there to support for the research and the capacity development. And so how I like to think about this is that if you look at coming in to help with outbreaks, is the opportunity to put out the fire, if you will, or help put out the fire. Then we like to ask the question with partners on the ground, what were the problems? Why did this fire begin? And those are the gaps in knowledge that we try to work with groups in country to provide some degree of answer through prospective research during the outbreak, if we can, if we need to, and then after the outbreak, if we can't, or before an outbreak in different places where we have ideas of particular diseases that are important and dangerous, and then work to help that no fire starts again, or that if it does, it's minimal and can be put out rapidly through our capacity development endeavors. So we are the UK Public Health Rapid Support Team. It's a novel collaboration in the UK co-led by the Public Health England, which is of course the government agency funded by the Department of Health and Social Care. We'll hear more about that in a minute, and the London School of Hygiene and Tropical Medicine. So we have a government academic collaboration. We welcome collaboration and expertise from not only across the UK, but across the world. And that's really one of our goals going forward, is to enhance our group. And it's not about controlling or the specific people who respond or groups that respond. It's really trying to have many contributors and get the best expertise really across the world that responds as one team. Not in isolation as the rapid support team, but of course collaborating with in-country partners and other international partners such as WHO and many others. We are funded then by the UK government. Despite the challenging economic environments produced by COVID, we are still funded and still exist, and we're happy to hear that, of course, and think that also really is a recognition of how important this work is. We're a relatively small team, what we call our core deployable team, and this is distinguishing it from a very skilled, excellent team that provides admin and operational support in London. But the people who get into the ground with technical expertise consists of a small number of epidemiologists, laboratory microbiologists, social scientists, clinical researchers, infection prevention and control experts, data scientists, field logistician, and a training team. And so this is our group that really can support when things happen, and also the group that helps to work out research and capacity development endeavors with our partners. So very multidisciplinary, meant to be multidisciplinary. The one thing that I'll mention that we are not, and we'll hear from them a little bit later on, we are not the group that provides direct clinical care. And so if there is a call from the UK for support for direct clinical care, that would be the UK emergency medical teams that come in and provide doctors and nurses and other clinicians on the ground in the wake of whatever it may be, an infectious disease event or an earthquake or whatever it may be. So we work on the public health side of things. Our team is ready to deploy within 48 hours of a request and approval. And so we can get onto the ground very rapidly. Most often when there are delays, it's more on the logistical side and working out visas and flights and things like that. But in terms of personnel, we're really ready to go very rapidly. And in order to do that, well, I'll get to that in a minute. Let me just say we're augmented by a cadre of field epidemiology training program fellows in the UK that we try to tap into their expertise and have them contribute to our team. And then also a multidisciplinary cadre of reservists. And so these are people who don't work full-time for the rapid support team, but can be brought in when we need their particular expertise or surge capacity and more of a particular function and expertise. And so we have a mechanism basically to bring them in, and also pre-arranged agreements with their employers to allow them to be released, and basically backfilling their jobs and pay so that they can be released to deploy. This takes quite a bit of preparation, and so this is not the sort of thing that one just puts their name on a list and says, okay, great, sounds interesting to me and I'm happy to do it. So the preparation includes one of the things that we're doing today, our induction day, we often call it, and just overviews for people who are part of the team, especially new team members, but others who are interested or haven't had the time to really catch up with what the RST is. Then everyone goes through an intensive field deployment course. So this is 1 week in the field. It's not meant to make you into an expert epidemiologist or laboratory scientist. It's really to give you the soft skills of working with partners on the ground and understanding how things are set up when you get into an outbreak setting with Ministry of Health and WHO and many other partners. Security, of course, is important. And so everyone goes through a 4-day, what we call Safe Plus training, security awareness in hostile environments. Unfortunately, this sometimes is necessary, and the team goes in on occasion to environments that where security is an issue. And then there's all the medical clearance and things to be sure that you are safe as possible, including vaccination and pre and post-exposure prophylaxis. Other briefings just in time on particular illnesses or diseases that someone may not be familiar with. It's not everyone who thinks about Ebola or diphtheria or Lassa fever every day, and certainly no one who thought about COVID-19 before it came out and caused this pandemic. We do get support from what used to be DFID, now FCDO, the merger of FCO and DFID for deployments, and work also with WHO in the field and have security provided by them when necessary, and we deploy through WHO. So this is just an idea of some of the safe training that you do. It looks quite sort of military in the image, but that's really not what it's about. We are not a military-oriented group. We are, of course, really work in health, but we also have to make sure that there's safety. And so people do learn how to put on a flak jacket and a helmet in case there are There are issues that come up. These are rarely used, but I will not say never used. And so, for example, in the recent outbreak of Ebola virus in Eastern Democratic Republic of the Congo, you're probably all familiar and read about that, fortunately over now, but there were considerable safety issues. And so we have to be aware of these sorts of environments and ready when things could happen. We deploy often, but not exclusively, at the request of international bodies. So those of you who are familiar with the Global Outbreak Alert and Response Network that works closely with the World Health Organization, they can put out a call for expertise and say, okay, this particular event is going on. And so we need support in terms of epidemiologists or laboratory support or IPC or social science or whatever it may be. And we try to meet those requests when we have that expertise. We can also do respond to requests that are government to government or national public health institutes directly from the UK. So we have responded, for example, to Lassa fever outbreaks in Nigeria on a few different occasions, and quite an active research and capacity development program with Nigeria CDC at the request of Nigeria CDC to the UK government. And then we work closely with the UK emergency medical teams, as I mentioned, and you'll hear about them in a little bit. This is just a partial list now, and of course it grows as we keep working. These are the outbreak deployments. So these are for outbreaks and not necessarily all the places where we might work for research and capacity development projects. So these are just the places where we've engaged in our almost 5 years of existence for outbreaks, sometimes in multiple times. We're usually in country for 4 to 6 weeks. Sometimes we replace personnel after that, depending upon what's going on. Sometimes the indications here on the slide are seem a little bit simplistic because, for example, the Democratic Republic of the Congo working for Ebola virus disease in 2018, started in 2018, but we had a presence in North Kivu almost throughout really the 2-year outbreak. So these can be quite extensive in some cases. We also may deploy in short periods to help with an assessment and what's needed, and then figure out with partners after that 2-week assessment mission, for example, whether that's something that we can supply or others, the Ministry of Health has it in hand, or other partners contributing. Usually we deploy in response to a particular outbreak of a specific pathogen. On occasion, we've deployed in a circumstance where we've thought, and in-country partners thought, there might be a particular dangerous situation. This is one such example here in Sierra Leone a few years ago, when there was, after heavy rains, a large landslide that you can see some of the damage, and just took out large swaths of houses, and affected quite a few people in these areas that were then put into displacement camps for a while to try to take care of them. And so you can imagine in this sort of setting where you have populations of people in relatively unhygienic settings, and then a lot of rain and water, so there's a high risk of waterborne disease such as cholera. So we worked at the request of the Ministry of Health of Sierra Leone, in this case, to enhance epi and lab surveillance for cholera and other waterborne diseases. That led to research projects after that and capacity development projects to enhance the Ministries of Health capacity to detect such diseases in the future. And so an example of how the outbreak itself, or the threat of an outbreak, led to identifying some gaps in the capacity and working with the country to fill those gaps, as well as to identify particular pathogens of interest in that area. Our research program, we will not have time to go over in depth our research program. We look at, these are 5 main themes that are common really for most of our work. You can see there epidemiology, microbiology, patient-centered research that's been led by collaborators at Oxford University in the last few years. Social science work, mental health and well-being, that's been led by collaborators at King's College in London. But these are, this is not exclusive. If I were to go over we'd need a whole nother lecture, an hour to go over all the research projects. It's somewhere over 25, perhaps, or 30 research projects that we have implemented over our time with various partners in different countries around the world. I'll mention that the majority of our work is oriented towards sub-Saharan Africa, but that's not in any way exclusive. And people often ask me, how do we decide where we work? And the easiest answer is it's where we get the requests. And so when a given country says we have a particular need or gap in knowledge or need support with an outbreak, then we try to see what we can do in that support. So it's mostly coming generated, as it should be, from our partners on the ground, not from us deciding where to go. I chose here just to put up a slide on a disease, Lassa fever. Some of you may be familiar with this. This is just an example kind of how the tripartite remit of outbreak response and research and capacity development come together. If you're not familiar with Lassa, this is a hemorrhagic fever virus that causes a disease in its most severe form, somewhat similar to Ebola. It's found in a rodent reservoir called Mastomys natalensis, or the multi-mammate rat is the more common name that you find across West Africa, and has a case fatality rate in hospitalized cases of around 20 to 25%. And so a dangerous disease that we see outbreaks that occur, especially in a few countries in West Africa, Nigeria being one of the primary sites. We've also worked in a lot of other places in Sierra Leone and Liberia and with this over the years, both through the RST and for me predating that. But you can see here the three aspects. So outbreak response over this is usually a seasonal disease where you see it during the dry season, and over 2 consecutive years, we receive requests to provide support for outbreak response and management of Lassa in Nigeria through Nigeria CDC. And so had different personnel in country with epi, laboratory, and logistical support skills providing to Nigeria CDC. But in the meantime, also looked at where were the gaps in knowledge. And you can see on the research side, there's a drug called ribavirin, for which there's quite a few questions about the efficacy of that drug for Lassa fever these days. The clinical evolution of the disease and the pathogenesis of Lassa are not particularly well known. And so we have studies looking at those and looking at the pharmacokinetics of ribavirin, which is necessary to really understand how effective the drug may be. Also a project for the development of an oral fluid IgG assay for Lassa, which would give us an opportunity to really understand how broad this virus is spread across West Africa, who's been infected in the past. A study also of Lassa negative samples in Nigeria. One of the things that always happens when you get into an outbreak setting is a lot of people fit the case definition, but then turn out not to have the disease of interest. So the question always comes whether they, what else do they have? And of course, that's extremely important to the patient. You don't want to know just that you don't have Ebola or Lassa. You want to know what you have. And so extremely important. And then looking at, on the social science side, healthcare seeking behavior for febrile illness, and then capacity development. You can see here development of clinical research capacity with partners in Kenema, Sierra Leone, and the Lassa ward there, and then technical insights to partners at the Coalition for Epidemic Preparedness Innovations, or CEPI, that we work with closely. So that's just an idea of how broad the research and capacity building and outbreak program are, but how they may come together to really synergize across those 3 remits of the rapid support team. I'll end with just 2 comments. First of all, if you're interested in more on the UK Public Health Rapid Support Team, feel free to look at these links. We do have an interest group and journal club. The second one, you can see the contact there. You don't need to be in London or have any particular expertise, but we certainly welcome you to get on our listserv there and be able to tap into different presentations and discussions that we may have on a regular basis. And then we were fortunate enough a few years ago to be chosen by Bill Gates to be featured on his blog, Gates Notes, and that gives you a little bit of more of a polished idea in Gates's way of our team. I'll end with also encouraging you. I don't have a slide here, but I like to encourage people to join a couple different societies, really. The American Society of Tropical Medicine and Hygiene and the Royal Society of Tropical Medicine and Hygiene are both important societies, really, to have global sharing of data and global opportunity. And so they're really easy things to join. I encourage you to look online for both of those, but it's really important, especially in this time where we're facing a global threat, to have global communication and a global coordinated response. And those are two ways to do that. So thank you very much for joining, and I will stop there.